Hello guys, today we are going to discuss trachoma. First of all, you should understand why trachoma is so important in conjunctivitis while we are studying ophthalmology. Okay, so basically saying trachoma is caused by chlamydia trachomatis. It is a gram-negative pleomorphic bacilli. It is caused by seroars A, B, BA and C. This trachoma, it is included in Vision 2020 program of WHO. So why we are studying trachoma? First of all, you have to understand that. So see, this is taken from the WHO website itself. It is the world's major infectious cause of blindness. So ultimately it causes blindness. So how? Basically this is written in infected community, infection is often first encountered in infancy or childhood. So first infection occurs in infancy or childhood. Then after that, it is written there are repeated infections. So relate a single infection is relatively innocuous. But what is the problem is repeated infection occurs over many years in the endemic areas, and this cumulative effect of many inflammatory episodes. So there is multiple inflammatory episodes and then the healing occur, and that will cause the upper eyelid to turn inwards. We'll see the technical terms of this later. So that the eyelashes rub on the eyeball. What happens when the eyelid turn inwards? The eyelashes, when we blink, start to rub on the eyeball, resulting in intense pain and scarring of the cornea. So corneal injury, scarring, and yeah, the eyelid turning inwards and the eyelashes turning inwards, trichiasis. That is called the trachomatous trichiasis, leading to blindness, irreversible blindness. So that is why trachoma becomes so important. So now let us see some details, a little details about the chlamydia trachomatis organism. So basically they belong to family Chlamydiaceae. In that, in the family Chlamydiaceae, there are two genera, that is the Chlamydia and Chlamydophila. Here, this Chlamydia trachomatis comes under the genera Chlamydia. Chlamydophila includes Chlamydia psittaceae and Chlamydia pneumonia. That will be dealt in microbiology actually. Uh, so historically, based on the disease they cause, this Chlamydia trachomatis is divided into, it is called trick agents and LGV agents, that is lymphogranuloma venereum, that is LGV, and trachoma inclusion conjunctivitis. So this trick agents, they can cause trachoma and inclusion conjunctivitis, and here it can cause lymphogranuloma venereum. So next, actually, this serotyping is important. The trachoma is caused by, as I've said earlier, is caused by the seroars A, B, BA, and C. This D2K seroars, they cause the inclusion conjunctivitis and the genital infections, and the L1, L2, L3 serotypes, they cause the lymphogranuloma venereum. So here A, B, B, and C, they cause the trachoma. So moving on to the disease proper, trachoma. It is the Greek word for rough, because in the end stage in chronic trachoma, the conjunctiva surface appearance. Now it is also called Egyptian ophthalmia. It is an old name. So what are the predisposing factors? So this is obviously the picture of a young child. So the primary infection is contracted in a very young age less than 10, and it has a slight female preponderance. and some racial preponderance is all there. But what is most important is the low socioeconomic status. In low socioeconomic status people, the overcrowding is there, and the unhygienic living conditions, the water is not clean, and these are the main problem. Unsanitary conditions is the main problem. So the, and also there will be environmental factors in these low socioeconomic condition, excessive exposure to dust, sunlight, etc. So these are some of the predisposing factor. Now, what is the major source of infection? So the source of infection is the conjunctival secretions or the conjunctival discharge of the affected person. Okay, so eye disease, it is a conjunctivitis. So conjunctival discharge of the affected person. So what are the mode of infection? One of the major modes of infection is flies. This is the eye seeking fly or the musca sorbens. So that is flies is there. Secondly, formite is there. So formite means like formites like towel, handkerchief, surma rods, etc. So formites, or and through fingers, right? Fingers of doctors, nurses, etc. And also direct transmission, airborne, waterborne can occur in unhygienic conditions. So mainly 3F we can remember: flies, formites, and fingers. Now, distribution of trachoma. So it is highly endemic in India. So the countries endemic for blinding trachoma, these African countries include Brazil is involved, and China, India. So India is involved, is very important. So this disease becomes very important. Now moving on. Now to the symptoms. So in the active stage, this in the active stage, trachoma infection alone is highly innocuous. So uh, absence of infection means in absence of any other overlying bacterial infections, right? In the absence of any other overlying bacterial infection or secondary infections, there will be just a mild foreign body sensation, occasional lacrimation, slight stickiness of the lids, scanty mucoid discharge. Unlike other bacterial infection where there is discharge, there is redness, there is, yes, mucopurulent conjunctivitis, like, but those symptoms are not seen if only chlamydia trachomatis infection is seen in active stage. So if overlying other bacterial infections are present, then there will be symptoms of mucopurulent conjunctivitis. Now moving on to the signs of the disease. Okay, so this is a table showing the signs in the active trachomatis stage and cicatricial trachomatis stage. So later on I will show you all the photos or the pictures of these, but just summarizing. Active trachoma. Active trachoma means there is active infection. So that occurs, as I've said earlier, the risk age group is 5 to 10 years or less than 10 years, not 5 to 10, less than 10 years, occurs in childhood. So conjunctival sign, there will be congestion, redness, there will be conjunctival follicles and papillary hyperplasia, mainly follicles, and also papilla can also be seen if child is within 2 to 3 months or less than 2 years. Also papilla will be more prominent. Now corneal signs, there will be superficial keratitis, Herbert follicles, I will show all these, progressive pannus formation, and later on corneal ulceration can be there. So these are the active trachomatis stage where there is an active infection by the organism. So in this stage, when we are going to treat the patient, we'll see it later, we will give antibiotics because there is active infection. Okay. Now cicatricial trachoma. So this cicatricial trachoma that is occurring because of, in the beginning of the video I told, infection along by chlamydia trachomatis is one infection, single infection alone is rather innocuous. But here, when recurrent infection occurs, when the patient reaches middle year, it causes a chronic immune response. So one infection is there, scarring is there. So more, and there will be an overlap of infection and scarring, right? These two episodes, and this chronic immune response lead to a type 4 hypersensitivity response. So the pathogenesis behind the cicatricial trachoma is said to be type 4 hypersensitivity response. Now in cicatricial trachoma we can see conjunctival scarring, that is Arl's line. I don't know the pronunciation correctly, ARLTS, Arl's line. And there will be conjunctival concretions. These are just the dead epithelial debris and all depositing. And there will be other signs like rarely you can see pseudosis, cirrhosis, synblephron. Not much important. Okay, rare. Corneal signs, you can see regressive pannus. Here you can see progressive pannus. I'll show you the difference and all. Hebert's pits. Okay, here also you can see Hebert's follicles and Hebert's pits. Now here you can see corneal opacity, corneal opacification that is occurring gradually. Then other blinding sequelae like corneal ectasia, cirrhosis, total corneal pannus. Actually, pannus first starts in the upper part of the cornea, then it spreads down. So in late stages there can be total corneal pannus. Lid complications, these two are very very important: trichiasis and entropion. Entropion inward turning of the lids, then trichiasis is eyelashes. Tylosis, ptosis, medrosis, not much important. Then in later stages scarring can cause chronic dacrocystitis and also infections, chronic dacrocystitis and chronic dacroadenitis. So mainly you should remember this trichiasis and entropion. Now let's see these in detail, a little detail. Now I talked about pannus. Now progressive pannus. So in pannus formation actually there is infiltration of the cornea. This is the infiltration, the follicles and all are involved. Infiltration of the cornea and vascularization of the cornea. First it is seen in the upper part. So when uh, infiltration of cornea is ahead of the vascularization. See, infiltration ahead of the vascularization, that is progressive pannus. Now, what is regressive pannus or pannus siccus? That is, vessels have extended a short distance beyond the area of infiltration. So this is the area of infiltration. The vessels have gone a short distance or just gone short distance ahead of the infiltration. So that is regressive pannus. Now in the acute trachoma I said there is conjunctival follicles or follicular conjunctivitis. So these follicles, these conjunctival follicles will resemble sago grain. This is sago grain. So this is pathognomonic of trachoma. So these are called sago grain follicles. Okay, you can see these follicles. This one, two, many follicles are there. So that resembles the sago grain. And so these follicles are present in the adenoid layer of the conjunctiva. Conjunctiva basically has three layers: epithelial, adenoid and fibrous layer. And here in the adenoid layer, the scattered aggregation of lymphocytes, that is leading to these follicles, and inside that follicles Leber cells can be seen, that is the large multinucleate cells that are present in the center part of the follicle along with, so the Leber cells are multinucleate cells. In addition, histiocytes, lymphocytes can also be seen in the follicle, and also signs of necrosis. So this follicular conjunctivitis can be seen in others also, in other infections also. Follicular conjunctivitis can be seen. in viral infections also we can see follicular conjunctivitis. But what is the difference? In trachomatous follicular conjunctivitis, there is sign of necrosis and Leber cell. These two are the distinguishing features. Differentiate trachoma follicles from other follicles. Now, pannus, I said, progressive pannus can be seen in active infection. Yes, along with follicles, papillary hyperplasia can also be seen, but majorly follicles. Now, moving on to the next one, Hubbard's follicles, and later on Hubbard's pits. Hubbard follicle that is occurring in the active state, that is in the limbal follicles, and when the resolving of the limbal follicles occurs, Hubbard's pits can be seen. So you can see 1, 2, 3, 4 like that. So Hubbard's pit, one has been indicated. So Hubbard's pits can be seen. Hubbard pit is seen in the uh, cicatricial trachoma, whereas Hubbard's follicles, this is here follicles can be seen in case of our active trachoma. So resolving limbal follicles leave the depression in cicatricial trachoma, that is called the Hubbard's pits. So once again, this is just to show the picture of a pannus formation. It is starting from the upper part. Now moving on, this is in mild cases of cicatricial trachoma. You can see scarring. Yes, of course, in cicatricial trachoma, cicatrization means scarring. So you can see scarring, stellate or star shaped scarring. Okay, like this. It is indicated by the arrow. So this is in mild cases. So when we go on to the more severe cases, there is a broad confluent scar that is between the that is at the region of the sulcus subtarsalis, that is between the lower one third and the upper two third. So the it is a everted lid. So the lower one third and the upper two third, there is a broad confluence scar called as the Alstrine, and this is seen in the region of sulcus subtarsalis. It is seen in cicatricial trachoma scarring. And now conjunctival contrition. So this is also seen in cicatricial trachoma. This is just pinpoint about 2 millimeter in size. These whitish spots, and these are accumulation of dead epithelial cells and mucus. Right, dead epithelial cells and mucus. Do not think that concretions are calcium or calcified deposit. No, they are just dead epithelial cells plus mucus. Okay, next moving on. Okay, the lid complications, cicatricial entropion and trichiasis. So you can see this is a entropion means what? The inward folding of the lids, right? That is the cicatricial entropion. Next is trichiasis, that is the eyelashes are turned inward. That is eyelashes that are normally growing outward are turned inward or malpositioned. That is called trichiasis, and during blinking or also normally they will touch the cornea and the conjunctiva. So even one eyelash that is turning inward, that can constitute a trachomatous trichiasis that has been mentioned by WHO in their staging. This is about the clinical features. So now let us just revise it. So in active stage, you can see congestion. I showed you about the conjunctival follicles. Now what is the basic difference between follicles and papilla? Follicles are lymphatic follicles, that is the scattered aggregation of lymphatic. So these are white raised spots, white raised structures can be seen. Papilla, it involves the increased proliferation of the blood vessels are involved, so it will be reddish spots, right? So follicles can be seen, the sago grain follicles and hyperplasia, papillary hyperplasia. Hubbard's follicles later on developing into Hubbard's pit, progressive pannus, rarely corneal ulceration. Again, in cicatricial trachoma, I showed you the conjunctival scarring, the Alstein, and also the stellate scarring that is seen in mild cases, and the concretions mainly. And then we also show the regressive pannus, Hebert's pits, and also later on leading to the corneal opacity. Okay, then we saw the trichiasis and entropia. Now about the WHO grading of the trachoma, it is called the Fisto classification, FIST and O. Now TF, that is trachomatous inflammation follicular, 5 or more follicles greater than 0.5 mm. Mainly these follicles are seen in the superior tarsal plate. They can be seen in other areas, but mainly superior tarsal plate. So that is the trachomatous inflammation follicular, 5 or more follicles. Next, I denotes trachomatous inflammation intense. I is for the intense, that is diffuse involvement of the tarsal conjunctiva, obscuring 50% or more of the normal deep tarsal vessels, and papillae are present. So intense inflammation is seen, intense redness can be seen. So involving 50% or more of the normal deep tarsal vessels. Then S, that is trachomatous conjunctival scarring. You can see the different scarring lines, right? Easily visible fibrous white tarsal band. You can see white scarring like this. Next, trachomatous trichiasis, that is the inward turning of the eyelashes. At least one lash touching the globe, as I said, is called trachomatous trichiasis. Then finally, it will lead to opacity. Just it is not the complete corneal opacity that we are calling the corneal opacity here. The sufficient to blur details of at least a part of the pupillary margin. That is enough to call it a corneal opacity. Now let us see. So this is taken from the WHO site. You can see the follicles, that is TF, trachomatous inflammation follicular, and you can see the intense inflammation follicular plus TI, that is inflammatory thickened tarsal conjunctiva obscures. You can see it obscures more than half of the normal deep tarsal vessels. So here you can see the tarsal vessels. So here the tarsal conjunctiva is thickened and it is obscuring the deep tarsal vessels. This is the normal conjunctiva. It is pink, smooth, thin, transparent. Over the whole area of the tarsal conjunctiva, there are normally deep lying blood vessels that run vertically. So this deep lying blood vessels are covered by the thickened conjunctiva in trachomatous inflammation intense. Next is trachomatous scarring. You can see the scarring, probably an Alstein. Okay. Then trachomatous trichiasis, that is the eyelashes rubbing. At least one is enough. We can call it trachomatous trichiasis. Then the corneal opacification. You can see there is blood vessel running over the cornea. Cornea is naturally a vascular structure, you know. And here the corneal opacification. The pupil margin is blurred, viewed through opacity. Such corneal opacity causes significant visual impairment. It can be 6 by 18, that is Snellen's chart, and therefore visual acuity should be measured if possible. Okay. Eliminating trachoma, accelerating towards 2020. So reading this, we could guess that I am going to talk about treatment next. So why called this year is 2020? So under the WHO program GET 2020, GET 2020 program, that is Global Elimination of Trachoma by 2020 program, WHO has adapted a strategy called the SAFE strategy that is aimed at the prophylaxis against trachoma infection and prevention of blindness. So SAFE has a full form, I'll say it. So it is aimed at prophylaxis against trachoma and prevention of blindness. So WHO defines blinding trachoma elimination as, so when we can say the trachoma is eliminated, that is basically when TF, that is the follicular pre- prevalence 5 percentage in 1 to 9 years. So basically less than 10 years children, when the prevalence of trachomatis inflammation follicular is less than 5 percentage or about 5 percentage. Now, or not or and, so both must be there. Trachomatis inflammation intense prevalence 1 per thousand in a total population. We'll take a district population or a sub district population, and in that 1 per thousand. So these two are the criteria that need to be met for calling a place eliminated of trachoma. Now, what is the safe strategy? It was implemented, or it was adopted by WHO under the GET 2020 program. In this safe strategy was adopted in 1996, and safe strategy S for surgery for advanced trachomatis disease. A, that is antibiotic to clear the active trachomatis inflammation or infection. Then these, that is the primordial one, that is the environmental improvement, and the primary one, that is the facial cleanliness. Now it's this just the same: surgery, antibiotics, facial cleanliness, and environmental aiming particularly at the access of clean water and proper sanitation. So this is the year 2020. This is a estimate in 2019. So taking into consideration 2002, there were number of people at risk were 1.5 billion, and it fell to 142 million. That is, there was 91 percentage reduction. So it was a somewhat successful program, right? So first one, in safe E, environmental changes. These are the primordial changes that need to be brought about. That is the environmental sanitation for providing the proper access to clean water, etc. Then the primary prevention, that is the facial hygiene. Why facial hygiene? That is, clean water should be provided to eliminate the potentially infectious ocular secretion. So the main mode of infection is the conjunctival secretion of the infected people. So if you provide clean water supply and also the proper drainage facilities, proper facial hygiene can be maintained, so that the disease spread can be prevented. And also the facial hygiene, we should all use our own towels, our own handkerchiefs, and sharing of surma rods and all should be avoided. So this will prevent the spreading of infection from one person to the other. Now let's come to the antibiotics that are used in the treatment. A, so antibiotics are administered based on like areas with 10 percentage or more prevalence of active trachoma. For active trachomatis infection, that is mostly 1 to, so this areas with 10 percentage or more of active trachoma, the children within 1 to 9 years of age are taken, right? So if it is 10 percentage the prevalent or more, then oral azithromycin 1 gram is the drug of choice now. So why oral azithromycin 1 gram? So it is just a single dose that is given, right? Up to 1 gram, so 20 mg per kilogram, maximum dose of 1 gram, administered to all the community members. Not only the infected child, it is administered to all the community members. But if there is any macrolide allergy or hypersensitivity, or like pregnant women and children less than 6 months of age, tetracycline ointment 6 weeks can be given. But what is the problem with tetracycline ointment? It has to be given for 6 weeks, so the patient compliance is less. We don't know whether they will take it or not. So this is just 1 gram, we can directly supervise them taking the drugs. So now how will you review it? Review the progress, like in a district or a sub district level, we are checking this. So the baseline prevalence of follicular trachoma in age 1 to 9 years is 10 percentage or more. Annual treatment should be undertaken for at least 3 years. So if in such an area where there is 10 percentage prevalence, the annual yearly this treatment should be given, and after 3 years we will review it. If it is 30 percentage or more, then annually 5 we'll give this treatment and we will review. Then second one, if it is less than 10 and more than 5 between 5 to 10 percentage, then targeted antibiotic therapy, that is the patient will be treated, any family member that is maintaining close contact and other close contacts will be treated, right? All the close contacts with that person will be treated. And if it is less than 5 percentage, treatment of the patient is recommended. Sometimes we may employ target antibiotic therapy, but mostly treatment of the patient is recommended. So this is talking about azithromycin. And also sometimes tetracycline ointment, erythromycin ointment can be given twice daily for 6 weeks, but the patient compliance is less. Now the S, that is the WHO recommended surgical technique for an advanced trachoma is bilamellar tarsal rotation. So for tracheasis, tarsal rotation, so it has turned inward, so we'll correct it through surgery. So what are the indications for eyelid surgery? Not all, this is taken from WHO site itself. So not all patients require operation. So if just one or two eyelashes are there, just epilation, that is it can be mechanical or manual epilation, or using a laser or using electrolysis, we can remove the aberrant lash, right? So maybe repeated epilation may be required. So this is done in particularly old patients and all, when just or one or two eyelashes are turning inward, we'll go for epilation only. So what are the definitive indications? One or more eyelashes which turn in and scratch the cornea. When patient looks straight ahead, here this, see, if there are one or two eyelashes either laterally or medially rubbing into the conjunctiva. Evidence of corneal damage from trichiasis and severe discomfort. These three are the definitive indications. So if there is defective eyelid closure, we won't do a tarsal rotation surgery. In children, for doing a surgery, general anesthesia will be required. So in a local setup, we can't do this. A hospital setup is required, because in under local anesthesia we can't perform in children because they won't be cooperating. So poor general health, of course we can't do a surgery in them. Now if corneal opacification has occurred, we can go for penetrating keratoplasty or keratoprosthesis. If severe scarring and all can occur, and we can along with this, as an adjuvant therapy, we can go for punctal occlusion and lateral tarsorrhaphy. This is to protect the cornea from further damage after the surgery. So this is all about trachoma. For more details about the surgery, I'll link the WHO manual for surgery in the description. Thank you.